Assalamu alaikum wa rahmatullah, bismillah ar-Rahman ar-Rahim. My beloved third year students, today we will be talking about primary impression for edentulous arches. Previously, we have talked about anatomical landmarks of edentulous patients in the upper and in the lower arches. And we've talked about the vocabularies that we will use in our prosthodontic module. But today we will be talking about how we will take a primary impression for these edentulous arches. Slight revision about the pathway of complete denture construction. It's not a revision, by the way. We will try in this semester to learn how to construct a complete denture. In the fourth year, you will learn how to construct a complete denture to completely edentulous patients. But now we will just give you all the theoretical background about it. We'll start with edentulous arches. The patient came to your clinic asking to restore his missing teeth. We can see here that they are completely edentulous. So this is the upper arch and this is the lower arch. Finally, we will have these. We call them denture. This is upper denture and lower denture. So we have to think of the pathway, think of the end result, and how we will reach this end result. The pathway of complete denture construction is divided into clinical steps and laboratory steps. In this module, you will take all the clinical and all the laboratory steps. The clinical steps start with examination and primary impression. And after primary impression, you will have the primary cast. The lab will make primary cast out of the primary impression. Then the lab will construct a custom tray. The custom tray, we use it in the clinic to make a secondary impression. And after we make secondary impression in our clinic, the lab will fabricate a master cast. The master cast, he will make also a base plate and occlusal rims to make them ready to the third clinical step, which is jaw registration or bite registration stage. After that, the technician will mount these wax rims into an articulator and will start the teeth setup. After teeth setting, the teeth will be tried in the patient's mouth in another clinical step. It's the fourth clinical step. We call it teeth try-in. After try-in, we'll start with the processing the denture, and the fifth clinical step is coming, which is called fitting of the complete dentures. In this lecture, we will be talking about only the primary impression, as if we have talked about the anatomical landmarks before, which supposed to explain why we examine our patients. So you may ask why I should take a history and a clinical examination to my patient. The answer, because you are the dentist and you are the decision maker who will make the decision, what should I do for this patient? The cases are not straightforward, so the decision is all to you. So you have to know the history and the clinical examination. You have to know everything about your patient and everything around the area that you want to construct a prosthesis in. Let's go back to some revision to the anatomy of the maxillary and mandibular arches. Areas of either maxillary or mandibular arches are classified mainly into a stress-bearing area or supporting structures, a peripheral areas or a limiting areas or a limiting structures, and a relief areas. We talked about them previously in details, but we will just revise them. If we look into the histological section, of the foundation of the dentures. It's made up of bone and covering soft tissues. As we see here, this is the bone, and this is the mucosa, or the soft tissues. And here is the denture base. So the denture base will be in intimate contact with the mucosa. So the denture base rests on the mucosal membrane, which serves as a cushion between the denture base and the supporting bone. The maxillary and mandibular stress-bearing areas is considered as we said before, we have a primary stress-bearing area and we have secondary stress-bearing area. It's the areas and the arches that will bear the stress, that will bear the occlusal loads. Okay, so in the maxilla, we have firm tuberosities, we have the hard palate on either side of the mid-palatine raphe, we have the alveolar ridge or the residual ridge, we have the rugae area. In the mandible, we have the buccal shelves, we have the retromolar pad, and we have the residual ridge, which is also called the alveolar ridge. As we can see here in these photos, this is the maxillary arch, and this is the mandibular arch. The primary stress-bearing area are generally a thicker mucosa and or underlying cortical bone. So that's why we consider the buccal shelf here. Here is the buccal shelf area, and here is the buccal shelf area, as we can see here. It looks like a shelf, by the way, lying horizontally. Okay, so it has a cortical bone. That's why we rely on these areas to bear the stress. Thicker mucosa, we have in the palate a thicker mucosa. Okay. The total area of support in the mandible is significantly less than the maxilla. And we have to remember these numbers. The edentulous maxilla is 24 centimeters square, while in the mandible, it's only 14 centimeters square on average, we can see. Therefore, the mandible is less capable of resisting occlusal forces because we have more area in the upper, more area to handle the stress. Again, we can see here the histology. You can see the epithelium, the lamina propria, the submucosa, periosteum, and the bone. It varies, by the way, and the patient's mouth is different. Even in the palate, it's different from place to another. And the mandible is different also from place to another. Mucous membrane, composed of mucosa and the submucosa. You can see here the submucosa, and here is the mucosa. The submucosa is formed by a connective tissue, varies from dense to loose areolar connective tissue. The submucosa may contain glands, fat, or muscle fibers and transmits the blood and nerve supply to the mucosa. Where the mucous membrane is attached to the bone, the attachment occurs between the submucosa and the periosteal covering the bone. The mucosa covering the hard palate and the crest of the residual ridge is classified as masticatory mucosa. The masticatory mucosa is characterized by well-defined keratinized epithelium and lack of tissue movements. It will be firm. When you press on this mucosa, you will find it is firm. As we can see here, this is the maxilla, and this is the fitting surface of the denture. So it's a replica. Okay, that's why we'll take an impression. We'll take a primary and then we'll take a secondary impression, and we will talk about them later. But here we can see everything on the denture is a negative replica of what in the patient's mouth. You can see here, this is the incisive papilla. We can see here the labial frenum. We can see this, the area. And here we can see it's called the labial flange. It's called here the labial sulcus. We can see here the labial, the buccal frenum. And here we can see the buccal notch. Okay, so the name is different, but it's related to the same anatomical landmark. On the lower, it's the same. Okay, I see here is the same as area as there. Okay, C7 is the retromolar pads. Okay, the residual ridge. So primary impression, why do we have to take a primary impression? Is to duplicate the anatomical areas and landmarks into a workable cast. يعني احنا ما بيصير انه كل الشغل يشتغل جوا البيشنت ماوث. time consuming، راح ياخذ ages واحنا بنشتغل اذا بدنا نشتغل على البيشنت ماوث directly. غير هيك ممكن نستعمل material that will harm the patient mouth. So we have to duplicate what's inside the patient's mouth. So we need to be accurate, precise, and careful. To take an impression, we have to have trays, materials, impression materials, and we have to master the techniques. So the clinician's goal when making definitive impression is to record as accurately as possible the shape of the mucosa overlying the alveolar ridges and hard palate together with the functional depth and width of the sulci. This is important, the functional depth and width of the sulci, because the mouth is in a status of function. We eat, we talk, we laugh. So all the muscles, all the mucosal membranes, everything in the mouth, the tongue is moving. So when we construct a prosthesis inside a patient's mouth, we have to consider the functional depth and width of the sulci, which are the limiting structures. And before we're taking an impression, we have to prepare the mouth. It's meaningless to take an impression while the tissues are in an inflamed status. We can see in this photo, we call this denture stomatitis, redness all over. We can't take an impression in this stage. It is essential that the oral tissues be healthy before impressions are made. Therefore, should be no distortion or inflammation of the denture foundation tissues. But if we have an inflammation, we have to resolve the inflammation. Some tips which might help you to take an effective impression is to leave the denture out for at least 24 hours before taking an impression. If the patient objects, use tissue conditioner. We will talk about them later. Maybe at the end of this year, maybe in the 4th year, you will take about tissue conditioners. They are very soft material that put inside, we can put them inside the denture that will help the patient to relieve the pain if they feel pain. Oral hygiene instructions is almost always indicated. What we use to take an impression, again, we will use trays. We have stock trays. Stock trays are ready-made trays. So they are constructed in either metal or plastic. Stock trays may be perforated and non-perforated. Okay, so they are stock trays. They found on the stock market. You can find them everywhere. So they are not customized to my patient. So I will take with them a primary impression only. So these are my stock trays. هذا التري اللي هي الأداة اللي راح تحمل الامpression material and we apply it to the patient's mouth. This is the lower stock tray and this is the upper stock tray. For completely edentulous patient, the cross section of the stock tray is rounded, as you can see here. It's rounded. This is the cross section of the tray. Here it's a metal tray. These are plastic trays. These are metal. These are perforated. You can see them perforated. They will let the material to go out from the tray while we're taking the impression, and we will talk about this later. But here, as you can see, it's not perforated. It's a metal tray. This for the upper arch and this for the lower arch. We use them for specific materials. Stock tray rarely fit to the jaws without tissue distortion, so they are not customized for each patient. They are on average, they will work. They come into sizes, size 1, 2, 3, 4, 5. So you have to apply the denture and you have to try it inside the patient's mouth to check if this tray will fit my patient or not. An edentulous stock tray that is approximately 3 to 5 millimeter larger than the outside surface of the residual ridge is selected. The space amount here قديش أنا عندي relief، يعني قديش التري راح يبعد عن المين anatomical landmarks بيعتمد على الماتيريال اللي أنا راح استخدمها، راح نحكي عنها كمان شوي. How is a stock tray selected؟ نطلع هون بالأبر، دخلوا جوا البيشنت ماوث. هون بنطلع على posterior borders عندي للتري. They should cover the tuberosity and the vibrating line. Anteriorly, also it should cover all the anatomical landmark with a space of around 3 to 5 millimeters. So in the maxillary distal extension covers to the vibrating line, allowing space and coverage of the tuberosities. شوف هون anteriorly how it covers the residual ridge. طلع هون الليبيال فرينم والسلكاي. تركين مسافة، يعني هون لازم يكون في مسافة بيناتهم اللي هي 3 to 5 millimeters. هاي المسافة حتى الامبريشن ماتيريال تكون فيها. شوف المانديبولر. The mandibular tray should extend to the ascending ramus. Ascending ramus كمان نفس الشيء anteriorly. It should cover the labial frenum. The tray is the most important part of the impression making procedure, so we have to select our tray accurately. If it's too large, it will distort the tissues around the borders of the impression. But if it's too small, the border tissue will collapse inwards onto the residual ridge. فبيعطينا false reading. So a properly formed tray enables the dentist to carry the impression material to the mouth and control it without distortion of the soft tissues that surround it. The preliminary impression، هون بنحكي preliminary impression هي نفس primary impression اللي هي الطبعة الأولية أو المقاس الأولي اللي أنا راح أخذه. should be accurate as possible، يعني أنا أحاول قدر الإمكان إني أحصل قياس accurate. Over extension of the peripheral border is preferred to under extension، لأنه حكينا الدنتر هون في عندي حالة من الفيزيكال retention. الدنتر كيف راح يمسك جوا البيشنت ماوث؟ ما راح يمسك ميكانيكلي، ما في براغي أنا أمسكها وأقدر إني أشدها وأثبت فيها الدنتر. الدنتر راح يمسك فيزيكلي. فكل ما كانت الاريا أوسع، كل ما حصلت أنا impression لمناطق أوسع، أنا بهاي الحالة بكون حصلت support أكثر. Therefore, it is advisable to select an impression material that has a relatively high viscosity. ليش أنا بدي viscosity عالية؟ بتعطيني extensions أكثر. Okay? بتضغط على التيشوز، بتعطيني تفرد أكثر، يعني مش بتفرد أكثر. يعني كيف بدي أحكي لكم إياها؟ إنه إذا كانت الماتيريال highly viscous يعني بتعطيني ريكورد أفضل للأريا. thereby allowing the material to compensate more easily for deficiencies in the tray. يعني إذا التري مش واصل لهاي المناطق اللي أنا بدي إياها، الماتيريال نفسها لأنها highly viscous it can support itself توصل لهاي المناطق. الماتيريالز اللي أنا بستعملها واللي suitable to take primary impression لإدنتشلس patient, we can use alginate, we can use silicone putty, we can use impression compound. رح نحكي عنهم بالتفصيل. الالجينيت تعطيني good details, must be poured immediately. شو يعني poured immediately؟ يعني لازم تنصب الطبعة أو القياس immediately as soon as possible. ليه؟ لأنها خصائص المادة هاي إنها يا إنها بتفقد الماء أو إنها بتكسب الماء إذا في ماء حواليها. فهي dimensionally not stable. That's why we have to pour it immediately. They can exhibit defects in the areas of the palate. Okay? فبهاي الحالة بدنا ننتبه. الالجينيت wax or compound may be added to the stock tray borders. رح نلاحظ هون التري لأني بدي آخذه بالجينيت، أوكي، فرح يكون perforated لأنه الالجينيت بهاي بفك بسرعة عن التري، فأنا بدي mechanical retention. ليش؟ الماتيريال بتطلع بصير لها mechanical interlocking after set. هون بدنا نعدل على البوردرز تبعت التري. ليه؟ لأنه هو متل تري ومش واصل لكل البوردرز. مشكلة الالجينيت إنه it can't support itself. يعني إذا في deficiencies موجودة بالتري ومش واصل عندي لكل البوردرز، الالجينيت ما رح يوصل. وإذا وصل ممكن وأنا بشيل الامبريشن من البيشنت ماوث إنه it tears easily because tear resistance للالجينيت عندنا واطي. The weight of the stone, if they are not supported by the borders of the tray, may be sufficient to distort the borders of the impression. هون بنحكي عن الستون أو البلاستر. يعني لما أنا بدي أجي أصب الإمبريشن وهي أصلاً معمولة من الجينيت، فإذا كانت البوردرز أصلاً تبعت الجينيت ثين ورقيقة ومش supported بصير لها distortion فبتعطيني false reading. هاي الماتيريال أوكي لما بنخلطها it's powder to liquid ratio، بنخلطها بعدين we load it in the tray، بعدين we put it inside the patient mouth. It is advisable لما بدنا ناخذ عند البالت إن أول شيء نحط material جوا عند البالت لأنها رح تطلع لنا void كبيرة، بعدين بندخلها بالتري. Okay, so this is an alginate impression. Here it's a step نقدر إنه بكوبي بنسل نقدر نحدد السلكس وين موجود عندي، نحط عليه خط على أساس إحنا لما نصب الإمبريشن لحاله ببين عندي على الكاست وين هم البوردرز. نيجي للماتيريال الثانية اللي هي السيليكون باتي. Silicone putty impression material is a highly viscous material. It will flow beyond the tray to compensate for under extensions of the stock tray. Once set, it will support itself if in this position. يعني هاي الماتيريال لما خلينا نحكي بتنشف بالعربي، يعني لما بتنشف بتظلها واقفة الماتيريال. Okay. It exhibits some degree of elasticity and so will record undercuts with reasonable accuracy. Okay. فهاي الماتيريال بنستعملها لما يكون في عندي severe undercuts لأنه فيها some elasticity. It's high viscous material often record surface details poor. Okay. فهاي مشكلة الباتي silicone material. نيجي على الامبريشن compound which is widely used، وهذا اللي احنا رح نستعمله بالعيادات ورح تستعملوه كمان باللابات. Impression compound, a thermoplastic material with high viscosity. Like silicone putty, the material will flow beyond the tray and will maintain position after it chilled. Not necessary to correct any under extensions of the stock tray. لأنها هاي الماتيريال it can support itself. ما في داعي نغير على extensions إذا كانت under extended. Addition can be made to it if part of the impression is deficient. هاي الحلو بهاي الماتيريال. Thermoplastic material and you can add to the material. مش بترجع تكب الماتيريال وترجع تاخذ جديد مثل الالجينيت خلاص irreversible. This material is thermoplastic. An impression compound it's high viscous means it records surface detail poorly. هاي إلها الدروباكس. it's non-elastic. هاي اللي بتفرق عن السيليكون باتي. it's non-elastic. فإذا كان عندي كوز، إذا كان عندي severe trauma، هاي الحالة I can't use impression compound. لكن إذا كان عندي mild, moderate undercut, it works. But it can often be rotated from these anatomic areas unless they are sharp and bilateral. يعني you can handle, sometimes you can handle undercuts using impression compound. But generally we can't use them in severe undercuts. كمان impression compound it has high value of coefficient of thermal expansion. هذا بيأثر لي بعد ما احنا بناخذ القياس. الماتيريال جوا البيشنت ماوث بتكون حرارتها أقرب ل 37، لكن لما نطلعها لحرارة الغرفة فالماتيريال بدها تتأقلم على الحرارة الخارجية لأنها ثيرموبلاستيك ماتيريال. فالأوتر سيرفيس عندنا بيكون cold، لكن الإنر سيرفيس بيكون لساته hot. فبهاي الحالة بصير عندنا internal stresses وبصير فيها distortion و poor thermal conductivity. أوكي، فهاي الأشياء بتأثر كثير على stability تبعت الماتيريال outside the patient mouth after we take the impression. So we have to pour this material the same as soon as possible. If impression compound or silicone putty is used, tray borders do not require modifications if they are underextended. No need for tray adhesive for compound, although it is necessary for silicone. Preloading in the mouth is not required as alginate. حكينا إنه الألجينيت عند البالت مرات تطلع عندي void، فبضطر إني أعمل preloading، يعني أخذ من الماتيريال وأحط عند البالت قبل لا أخذ الإمبريشن. The tray is seated in the mouth in exactly as for alginate material، يعني seating هو نفسه. هلا بدنا نحكي كيف بدنا ناخذ الإمبريشن. في هاي الحالة if I want to take a lower impression to the lower arch, it's better to sit, okay, or to stand. إذا بدنا ناخذ هذا clock، okay, it's on clock 8. فهيك بتكون البوزيشن تاع الفيزيشن بالنسبة للبيشنت. clock تقريبا 8. If I want to take an upper impression, usually it's preferred to be behind the patient and clock 10. Okay. نفس الطريقة في هاي الحالة. Here we're taking a lower impression. Lower jaw must be at تقريبا level of our elbow. I want to take an upper impression. نفس الإشي ال upper arch بده يكون تقريبا على مستوى الإلبو تاعي. هون البوزيشن تاعي بالنسبة related للبيشنت تقريبا clock تقريبا 8. هون كمان بيكون clock تقريبا 10. لازم نهتم بشغلة إن دائما نفكر بالنهاية. Begin with the end in mind. يعني أنا بالنهاية إيش بدي أحصل؟ بدي أحصل دنشر، بدي أحصل well-fitted دنشر. فأنا رح أسعى إني أحصل well-fitted دنشر عن طريق كل هاي التكنيكس اللي أنا بدي أتعلمها، والثيوري اللي أنا لازم أكون عارفه، والanatomical landmarks اللي أكون عارفها. So we have to record the impression accurately. شوية مراجعة بس للريتنشن والسبورت والستابيليتي اللي إحنا رح نعتمد عليهم بالنسبة للدنشر تاعنا. Okay, so our denture should be retentive, should support اللي هي occlusal forces, and should be stable. Retention is the resistance of the denture to removal in a direction opposite that of insertion, away from the tissues. So the denture is retentive. The denture, it won't fall down from the patient or will take off out of the patient's mouth while function. Support is the resistance of the denture to displacement towards the tissues. It's the occlusal forces. When they exert occlusal forces on the denture, it should resist these occlusal forces. Stability is the resistance of the denture to displacement in any direction other than the path of insertion. So the denture must be stable. It shouldn't move. While we are talking, while we are eating, while we are smiling, all of these, the denture should be stable. Different concepts in tissue displacement. Soft tissues are displaceable. This is a rule, from 1 to 3 millimeters. So should the impression be taken in the static or displaced relationship? لما أنا بدي أجي أخذ قياس، إحنا حكينا مش في عندنا ميوكوزا وسب ميوكوزا وبون. هلا هاي الميوكوزا we can compress this mucosa, we can displace this mucosa. فأنا لما بدي أجي أخذ قياس، هل أنا لازم أخذ هذا القياس وأضغط على التيشوز كثير ويصير لها displacement، ولا أخذها وهي static، هي في مكانها ما تتحرك، أوكي؟ ما تنضغط. We have 3 techniques applied. We have a mucostatic technique. That's when we take the impression while the soft tissues in their static status. We have mucodisplacive or mucocompressive technique. This when we take an impression, we exert the pressure on soft tissues and displace them. Selective pressure technique, it's when we're taking an impression, we exert the pressure on some parts of the arch, and in another parts of the arch, we don't place any pressure. If the minimal pressure is applied to tissues and therefore records their resting shape. Here, distribution of the occlusal loads will be uneven on إذا إحنا أخذناها بالmucostatic technique. However, physical retention will be optimal. Okay, on physical retention. Okay, we're talking about retention. ليه؟ لأنه denture base, okay, is in even contact مع tissues. Okay. While if we took a mucocompressive or a mucodisplacive technique, if more pressure is applied to the tissues and therefore record their displaced shape, distribution of the occlusal load will be even. يعني occlusal loads لما يصير لهم distribution رح يتوزعوا بالتساوي على كل مناطق الارش. However, physical retention will be reduced. ليش physical retention will be reduced؟ هون ما رح يكون في عندي intimate contact بين fitting surface تاع الدنشر تاعي وبين التيشوز. ليه؟ تخيلوا هون displaced tissues بالأصل كانوا هون. This is the resting shape of the mucosa. If we displace them, ضغطناهم نزلوا لهون. بعدين بيجي الدنشر base. الدنشر base is okay بركب على الميوكوزا وهي بالميوكوكمبرسيف ستيت. لكن لما يكون في عندي resting ترجع الميوكوزا ترتاح تطلع، راح يكون عندي gap. Selective tissue displacement technique، بس تفهموا الكونسبت تبعها. primary supporting area and compressed secondary supporting areas are not compressed. Periphery under compression to achieve seal. طبعا يعني رح نفهم شو مبدأ السيل اللي رح يصير عندي بالدنشر and how we will achieve retention in complete denture. اوكي هون عندنا الupper arch. لاحظين هون في عندنا special case لما تكون عندنا الميوكوزا is fibrous والميوكوزا كمان بتكون فيها hyperplasia وبتصير كمان موبايل. فبهاي الحالة أنا إذا بدي أضغط على هاي الأنسجة وأخذ قياس والأنسجة ضاغطة، لما بدي أجي أركب الدنشر رح هاي الأنسجة بعد ما تنضغط رح يصير في عندها ستريس وتحاول تطلع الدنشر من مكانه لأنها بدها ترجع لوضعها الطبيعي. بهاي الحالة I should use a selective tissue displacement technique. هاي الحالة هاي المناطق لازم أخذها mucostatic والمناطق الخلفية أخذها mucocompressive. فبهاي الحالة بناخذ اللي هي special tray. كمان شوي رح نفهم شو يعني special tray ورح نقص في مكان، وبعد ما نقص هذا المكان رح نرجع هون ناخذ قياس بماتيريال بتعطينا mucocompressive، وهاي الفتحة رح ناخذ فيها قياس ثاني بماتيريال ثانية اللي تحافظ على الأنسجة وتضلها في نفس المكان. has a different concepts in tissue displacement. Should the mucosa be recorded in resting state or in displaced state? هون في عندنا concepts مختلفة. يعني ناس بتحكي mucocompressive، ناس بتحكي mucostatic. There is no evidence to indicate that one technique produces better long-term results than the other, but the choice is made by the dentist on the basis of oral conditions. يعني شو الأورال condition عندي، شو الوضع اللي عندي، هون بيهمني كمان اللي هو الكلينيكال examination اللي بيحدد لي. In most maxillary cases usually mucostatic technique. ليش؟ لأن حكينا الريزيدوال ريدج اللي موجود عندي بالماكسيلا is secondary stress bearing. In most mandibular cases usually mucodysplasia. Okay, this is mostly, this is generally. بس في حالات معينة، في حالات اللي إحنا رح نأخذها مع بعضنا بالرابعة وللأمام رح تلاقوها إنها ممكن تختلف من arch إلى آخر. How to control the displacement of tissues by the viscosity of the material. كل ما كانت الماتيريال high viscous شو بتعطيني؟ mucocompressive، تضغط أكتر. Spacer in the tray. قديش أنا خليت مسافة للمادة جوا التري حتى تعطيني الريكورد تبعي، حتى تقيس. هسا إذا أنا مثلا كمان شوي رح ناخذها اللي هو الزنك أكسيد يوجينول، إذا أخذناه بكلوز فيت يعني ما خليناش فيه سبيسر رح يكون ميوكو كومبريسيف. أوكي. Size and distribution of perforations in the tray. هلا إذا كان في عندي perforation زي ما شفنا البرفوريتد tray هاي mucostatic compression. هنا كمان رح نرجع نحكي لكم عنها اللي هي الدنجر بيس. هون الميوكوستاتيك هون ميوكو كومبريسيف. هون الدنجر بيس طلعوا هون لما التيشو ترجع مكانها. هلا من بعد ما اخذنا البرايمري امبريشن تبعتنا we have to fabricate الكاست اللي هو الكاست البرايمري كاست اللي انا راح اشتغل عليه حتى اعمل كاستم تري. انا بدي اعمل تري كستمايز للبيشنت تاعي. I have to pour the impression the primary impression with the plaster. كيف بنسميه plaster of Paris لونه ابيض. I pour the impression لانه انا ما بدي يعني ما بدي قوه وصلابه عاليه. That's why I don't use stone. I use plaster. I pour the impression I formulate my cast. هذا الكاست اللي عندي. اوكي. الكاست لازم احافظ. شوفوا هون بيطلع عندي الاوكلوزال بلين وهون عندي البيس تبعت الكاست. I have to trim it. هذا كله راح نتعلمه باللاب على التريمر حتى بالاخر يصير عندي هذا كاست workable كاست انا بقدر اشتغل عليه. طالع عندي كل الاناتوميكال لاند ماركس. طالع عندي شوف الفرينم كيف طالع واضح. شوف التيبروسيتي كيف طالع. شوفوا هون بوست دام اريا والفايبريتنج لاين. اوكي. طالع عندي البلد، طالع عندي الروجي اريا. فهذه دليل على انها الامبريشن تاعتي ممتازه. اوكي. ف if I want a perfect cast I have to take a perfect impression. and thank you و good luck. واي استفسار انا جاهزه وبنشوفكم بالله باذن الله.